So good afternoon, my name's Laura Evans. I am the Professional Practice Educator at the Trent Simulation Centre. Thank you for joining us today as part of the EEE conference. We're going to talk a little bit about virtual simulation today, and I'm joined by one of my colleagues, Eleanor Douglas.
Hi, I'm Eleanor. I'm a lecturer practitioner physiotherapist, and I work at the University of Nottingham and at NUH in critical care.
During today's session, we're firstly going to talk about a project that we partook as part of a trial between Nottingham University and Trent Simulation Centre, looking at the use of virtual simulation with undergraduate physiotherapy students. And then we're going to give you the opportunity to participate and observe in a live virtual simulation, and then that will be followed by a live Q&A session with myself, Eleanor, and the team from the Trent Simulation Centre. So like I said, back in May this year, we undertook a pilot project, a joint venture between the School of Physiotherapy at the University of Nottingham and ourselves at the Simulation Centre at NUH, looking at how we could deliver the simulation session that we normally deliver for these students, but in a virtual environment due to the COVID-19 pandemic.
The background to this project is that I convene a cardiorespiratory option module for third year undergraduate physiotherapy students. And this year we had 17 undergraduate students on the module, and we had planned to undertake a high fidelity simulation training with them that's based on the acute illness management AIMS course. And the idea behind performing the simulation is to give the students a taste of simulation and help them to explore the assessment and management of the acutely ill patient. So the assessment and management of the acutely ill patient is something that we've identified that students often don't feel confident in. They're at the end of their course, so they're in their third year. They will have normally had clinical placements, and some of them may have experienced being part of a situation where a patient becomes acutely unwell. And we know from previous discussions with our undergraduate students that this is an area where they do feel that they would like to improve their confidence. So what we would normally do with these students is we would take them in small groups to the Trent Simulation Centre, and the plan would be to normally perform a face-to-face high fidelity simulation. So unfortunately this year that couldn't be undertaken because of the COVID pandemic. So Laura and the team at the Trent Simulation Centre developed the idea of performing the simulation virtually. So this is what we did, and in a moment we'll tell you about some of the practicalities of doing this. So in order to prepare the students for the virtual simulation, we prepared them mainly as we would have for a face-to-face simulation. So just a bit of background really, within physiotherapy, simulation isn't embedded in the course at the moment. So these students undertake this simulation as a one-off in their final module, the cardiorespiratory option module. So the majority of students have possibly had an acute placement already. So the rationale is really to assist them to develop their skills in using the A to E assessment approach as outlined by the AIMS course, and then to also undertake A to E management strategies. And some of the management strategies they're familiar with, such as A, B, and C, but D and E are strategies that they're less familiar with. And we also prepared them by asking them to prepare and to deliver and educate them about the SBAR handover. So before we went into virtual simulation day, what we did is we spent a day with the students describing the rationale behind A to E assessments, how to manage somebody when they're acutely unwell, and how to use the SBAR as a structured handover to either call for help or to hand over the patient to another healthcare professional when it was at the point in the A to E assessment or management where they felt they needed help. As the students had never undertaken a simulation training before, we also spent some time inducting them around the principles of simulation and the principles of debrief. So in order to perform the virtual simulation, previously, we'd also done it with a previous year group, so we had a number of scenarios readily prepared. And basically, we mirrored the virtual simulation with the face-to-face simulation. So we divided the whole cohort of students into 3 groups. So there were 6 students in each group when they attended the simulation session. So 6 students attended for 2 hours, and we split the students into 2 groups of 3 so that they both performed a simulation with a scenario, and then they also observed their peers perform a simulation with a different scenario. So on the day, the students joined us via MS Teams, and they received a verbal referral or a verbal handover as they would have normally in a ward situation. The faculty, so myself and another colleague, then acted as virtual hands. So we were based in the simulation suite with the simulation mannequin, and basically the students then went through their A to E assessment, and they told us what to do, being their virtual hands. So for example, if they wanted to take the patient's pulse to feel the threadiness or to feel the quality of the pulse, then we would do that and report the information back to them. In the simulation suite, they also had a running observation screen, so they could see the patient's heart rate, blood pressure, saturations, and any information that they wanted further about the assessment of the patient during the A to E assessment. We performed that and then reported back to the student what the findings were. Acting as their virtual hands, we also employed the management techniques that they requested. So for example, if the student requested that the patient was put on a non-rebreathe mask or a trauma mask, we would instigate that. But if there was detail missing from the students, for example, how many litres to put on, and if they didn't tell us to occlude the valve to allow the bag to fill, we would ask them how exactly they wanted us to perform that before we applied it with the patient. So the practicalities were that the students joined the simulation session via MS Teams in a group of 6, 3 of them performing the virtual sim with 3 of them observing, and then vice versa. We needed additional cameras in the simulation suite in order to transport the simulation model and the monitoring, so the students could see the mannequin, they could see the equipment that was available to them, and they could also see myself and my colleague actually performing the assessment and management techniques as they requested us to. This obviously also required additional audio, to the faculty in the sim suite. So myself and my colleague had to wear a microphone so that the students could hear and also we could hear what the students wanted us to do, so we could report back to them the findings and the patient's response to their management and assessment. Obviously, this required technical support. So the technicians working at the simulation centre had set all this up and trialled it before the virtual simulation went ahead. But on the day, it was surprisingly seamless. We only had a couple of incidences where we lost a bit of sound, but overall, the technicalities of delivering this, the virtual simulation were pretty seamless and fairly straightforward from our perspective, but we did need that technical support from the simulation team.
What we made sure we collected was quite a lot of data surrounding how the students felt, both prior to completing their virtual simulations, initially straight after completing, and then as part of a focus group follow-up a month down the line. This table here just demonstrates some of the outcome data that we collected. So before completing their simulation, we asked all the students to complete an online questionnaire, and we were unable to tell who had completed that, so it was an anonymised data, completing a Likert score of how confident they felt with each of these 11 situations or actions that are important to assessing and treating a clinically unwell patient. So 0 being not at all confident and 5 being extremely confident. So as you can see, the pre-course ratings were relatively low, particularly in the areas of initiating management, making recommendations of what to do if you've got an acutely unwell patient. And then we asked them to complete this again at the end of their virtual simulation session. So exactly the same questionnaires in the same online format that they could access from home. And as you can see, that there was change within all questions, but for us as faculty delivering this course, what we found very interesting was, compared to previous years when we've delivered this face to face, actually when we delivered this remotely, there was more change, or significantly more change, seen in specific areas surrounding the students knowing their role in their management of the acutely unwell patient. And also in making recommendations and initiating that management. So we hope that this is what the virtual simulation had delivered. This was our hope, that we would improve their confidence, and this data at this stage does show this. And initially, after they took part in the virtual simulation, that did happen. Obviously, we would like to consider this going forward, see if this has any carry-on effect. Currently, these students have just qualified and now going up into clinical practice. And following them up may be quite difficult. So this were the initial findings, and obviously we want to know how that translates further down the line. The other data that we wanted to collect from the students is actually what they felt they learnt from the day. So numbers are all well and good, but actually sometimes their opinion tells you more. So of all the learning points that we collated, they were divided into these 4 kind of key areas. So the main one was having increased confidence after participating in this virtual simulation. And that was reassuring because it backed up the numerical data which we had. There was lots of discussion around learning points about utilising an A to E structure. So actually being able to use that structure, use it in a systematic approach, and the use of that structure in reassessment. So being able to go back through and utilise that again by observing, but also in a fluid motion with a patient, which some of our students may not have had experience of clinically with an acutely unwell patient. And luckily for us, as well as the clinical and technical aspects that we hoped to draw out for these students, there were also non-technical aspects such as communication and teamwork that were highlighted, and the importance of those. So even though we were delivering this simulation virtually, so these students aren't in the same room, they were still able to draw out actually that they learned the importance of communication, even though it was via a virtual platform, and the importance of that teamwork, even though it would felt very different from maybe how they carry out that in clinical practice or had carried that out previously in their learning, in face-to-face learning at university. So going forward, like I said, we in conjunction with the University of Nottingham, completed a focus group. So I'm going to let Eleanor talk to you about kind of the questions that were asked from that focus group and why we asked those specific questions.
So about 3 weeks after the virtual simulation had taken place, we asked if any of the students would volunteer to undertake a focus group just to add some depth to the findings that Laura has just discussed. 7 students volunteered to take part in the focus group, and this was conducted by Fiona Moffat, one of our colleagues who wasn't actually involved in the simulation delivery. So the students joined Fiona again by MS Teams, and Fiona posed questions to them about their expectations of sim, the purpose of it, the technical aspects, how it felt to them, what the learning points they got from observing simulation virtually, and anything that they would change. So we haven't fully explored the focus group findings in detail. We still need to do the analysis of this, but to give you a taster, we're just going to play some of the excerpts from the students about their experience of virtual simulation. So these were 2 of the reports that the students told us about their expectations of simulation.
We've graduated, like some of us have jobs already, and when someone has employed you to do a job and you're sitting there like, I don't know what to do with this patient when their stats are dropping, and they're like, and it just sort of, I was nervous because I was like, am I good enough to do the job that I've now been given? So that was quite intense, I thought, but it was a really good opportunity to kind of make mistakes, as everyone was saying, in a nice environment. So I think that was really helpful.
I think I'd heard like people from previous years had done it, and I was petrified, I'm not gonna lie, like going into it thinking that I've got people watching me in a little box and then there's just me treating this mannequin. So I think I was nervous for it, but then I thought ultimately I'd rather have that and practice on a mannequin and practice in an intense environment where it's not a real patient than going straight into like a deteriorating patient in real life. So although I was petrified, I was like, no, this is gonna be good for me.
So one of the things that we recognised there was that the students were quite nervous, and they did find performing that, it was quite a nerve-wracking experience. But as you can hear from both those excerpts, the students both felt that it was actually a beneficial way of learning, and it gave them the freedom to make mistakes if they did, which they didn't, in a safe environment. We'll now look at some of the feedback around the purpose of the virtual sim.
For me, because I was meant to be on I was on ICU for 2 days and then they cancelled it. And I haven't seen any acutely ill patients before, so my confidence was literally 0 before going into it. I think the fact that we were in groups of like people that we knew, it kind of helped to kind of almost suggest something, and even if you think, oh, I don't know if that's right or not, they'll just pick up the pieces after. So it kind of gave you the confidence to kind of try things that you might not have tried if you were by yourself, which I thought was helpful.
It was really useful, and especially to be able to watch another group do it, because like you said, it all happens like at ultra speed when you're doing it yourself, but when you watch somebody else, you're able to see a bit more of the logical A to E approach. So it kind of really solidified that process, and like learning from other people's wrong or right moves was definitely useful.
I've literally had no respiratory experience, no acute care experience. I was so nervous about going into a job having never seen a patient with COPD before in my whole life. And that's one of the things that they asked me about on my job interview. And I was like, I had to come clean and say that I'd not done any respiratory practice, and they were really reticent about giving me a job when I'd not had that experience. But because I was doing this module, and because I was able to talk about my sim training, and I was able to kind of say all these things that I'd learned, they gave me the job.
So this feedback really reflected around the confidence issue, and We were surprised at how unconfident the students were, and the fact that because of the COVID pandemic, they weren't able to complete 2 of their final placements, their elective and also a scheduled placement, that they'd found the sim really useful to help improve their confidence. So we'll now hear some of the feedback from how it felt.
I think I found the observation almost as useful as actually doing the scenario yourself, because I think, like it's been mentioned before, it's very different when you're sort of sat back and you're not on the screen at all and you're just eyes looking at it. You can start to think, oh, maybe I'd have done this or I'd do this now. And so you can, without any pressure at all, you can start to think in your head about what you'd actually do in that situation without actually having to do anything, speak, touch the patient, whatever. So I think that the observation was really helpful. And then I think sort of you miss things when you're in your own sort of simulation. So I think then hearing the feedback from those that had been observing you was really beneficial, because you sort of think, oh, okay, yeah, like I can see how that would have come across now. And I think, yeah, we would have done that differently. So I think that the observation was a really good addition.
I found it really useful observing someone that I knew that was in real time, because you watch the people on YouTube do it, and it's either scripted or they're complete experts. And so seeing someone the same level that's had the same amount of training as you do it gives you time to think, and B, reassurance that you can miss things and you can go back to them and things like that. So I think it definitely helped seeing it in real time, because it's not always going to be as slick and as fluid as going from A to E in a really perfect way.
So these findings reassured us that the students found the observation of the virtual simulation of their peers just as useful as actually being in the simulation themselves. In fact, some students almost found it more useful being able to observe their peers and have a little bit more time to think and reflect on what they would be doing, rather than being when they were in the simulation situation themselves. So we'd now like to share some of the key learning points that they fed back to us.
And you're like, am I actually a good physio? Like, I don't even know. I'm going into this job where people are going to trust me to do something. Am I going to know what to do? Am I going to know what a Goodell airway is? Before the simulation, no, I didn't know what that was. So I think, for me personally, it made me confident that actually I can do it, and that actually I am a good enough physio in that situation to know what to do, and to keep my patients safe, which is a huge worry of mine, I think, going into a job. So I think for me, the kind of confidence, the self-confidence, it was a massive boost that I really needed at that point. So yeah, grateful for that, I think.
Been the whole time being like, oh, I haven't done a respiratory placement, like that's where all the ill people will be. Like I'll be with the nice stable patients who have I don't know what I was thinking, but it really put into perspective that I could go over to a patient and they could just not be very well.
I learned, like everyone's mentioned, there was a lot of the sort of clinical skills, but I think it really highlighted to me the importance of communication within the team, and that was something that I think that sort of observing the other team as well, and you can see sort of how effective communications can sort of benefit the patient and sort of progress sort of the treatment along. So I think that sort of stood out to me, as well as all of the different clinical skills that we got to practice.
So I think these learning points, are really important, and we were really pleased that, the students felt that they learnt both clinical skills and skills in human factors and how to communicate, particularly if you've got an acutely unwell patient. And finally, we asked them, what would they change?
I think I could definitely compare the two, having done simulation in real life and having done it virtually. There was hardly any difference, really.
Having done it was, I really wanted another go, like another bite at the cherry, because you learn so much from doing it yourself and then observing, and then you have a bit of time to be like, oh, I should have done that.
So we found these comments reassuring that students still found it a really valuable experience, and the student that had experienced face-to-face sim found virtual sim, just as educational as well.
So going forward, jointly as a venture between the University of Nottingham Physio School and ourselves at the Trent Simulation Centre, we want to go on to develop this virtual simulation programme going forward, and its utilisations in other areas of physiotherapy education, but also how we can utilise virtual simulation as a resource for our staff at NUH, and how what we've currently delivered or previously delivered, or courses that we've not previously been able to deliver, how this might be a platform going forward. We're currently in the process of writing this project up for publication, so watch this space as NUH becomes more knowledgeable about this virtual simulation kind of programme going forward. So the next steps for us really are to kind of have a think about what you would think about, or what would be useful, or what infrastructure would be useful for you as staff members at NUH and educators at NUH and in university education, and how we could utilise that going forward. And I'd love to be able to discuss that with you in the live Q&A session. That would be great. So the next steps now is we'd like to invite you to participate or observe in a live virtual simulation. So we are going to transfer over to that now. So there will be a screen following on your MS Teams call with the next steps. After that virtual simulation, we will be around for a live Q&A session. So thank you very much for your time. We look forward to letting you observe and take part in our virtual sim. Colleagues, Paul is joining you via MS Teams at the moment. He's going to be the candidate for this afternoon's simulation. So normally we would have spent a lot of time briefing our candidates about what to expect from the simulation, doing a lot of work outlining that simulation uses a safe education space, so making sure that we're allowing our candidates to discuss with no judgment about what they found in the simulation, about how that would affect them clinically. We would have also, because this would have been a virtual or remote simulation, briefed our candidates on how they interact with us and interact with their clinical professional that's in the room, so me, and the kind of environment in the bed space. So we've already done that with Paul, our colleague. So Paul, I believe you can hear and see me.
Yes, good afternoon, Laura. Good afternoon, everybody else. My name's Paul. I'm a nurse by background, and I'm currently working alongside Laura as practice educator at Trent Sim, and I believe I'm going to be your candidate for the simulation this afternoon.
So we will start and run through a simulation, like I said, and then we will go through and then do a Q&A afterwards. So the space that we'd normally debrief with our candidates, we'll do a Q&A about virtual sim. So on your screens, you will be able to see the sim centre and our interaction, and then observations and results will pop up on your screen. You'll be able to view those kind of as we go through the same time that Paul's able to review that information as well. So I'll just give you a bit of a brief to this scenario. Our patient is Jenny Smith. She had her appendix out 4 days ago. She's been struggling with pain ever since. And as the nurse looking after this patient, you're just answering the buzzer that Jenny has pressed. So you are coming into this situation with responding to Jenny pressing that buzzer. Okay.
Okay, so good afternoon, Jenny. You've just pressed your buzzer. What seems to be the problem?
Hello. Yeah, oh gosh, I'm in such pain. I need something for the pain, I really do.
Okay, I hear what you're telling me. I'm just going to check your drug card very quickly to see what you've had recently. Have you had some pain?
Yeah, I mean, it's just, yeah, it doesn't seem to be touching it at all at the moment.
Okay, so I'll just have a check of the drug chart.
So Jenny has had her 2 o'clock regular pain medication.
I see. So is there anything available for me to give PRN for breakthrough pain?
And there's nothing due until 3:15.
Okay, Jenny. So what I'm going to do then is I'm going to speak to the doctor very soon, but I just want to do an assessment with you before I call them, just to make sure that we're not missing anything. Is that okay? It won't take long.
Yeah, that's fine. Okay, that's fine.
So I can hear Jenny's talking to me and making reasonable sentences, so I'm reasonably happy that her airway is clear. I won't need to use any manoeuvres or adjuncts to support her airway at the moment. So I'm going to move on to Assessor Breathing. Could we pop on the saturations probe for Jenny? Just so I can get her oxygen saturations and her pulse from that as well. That's smashing. So we'll just wait for that to pick up, Jenny.
Okay, thank you.
Okay, and we should be having your pulse coming up on there as well, I think. What I'm going to do while we're waiting is I'm just going to get a little bit of oxygen for you, just to help with your breathing. Okay, and I think what we'll do is we'll start with 15 litres non-rebreathe, but we'll probably be able to titrate that down over the next few minutes, but we'll just start with that because we have it available as emergency equipment. I just want to stay with you, Jenny, just while we're doing this assessment. Just going to attach that at the back of the bed space. You might hear a strange noise, some hissing, but it's nothing to worry about. That's it. So we're going to let the flow meter up to 15 and then just fill that reservoir bag. There we go. Just over the back of your head there, Jenny. Feels a bit strange, but just breathe away normally. You can still talk to me. Okay, so what I'm going to do now is I'm going to come round the bed again. I'm just going to continue with my assessment. I'm just going to pop my hands on whilst keeping a close eye on Jenny's chest, just so I can assess for the respiratory rate, the depth of breathing, the regularity and the symmetry. So I'm just going to take a minute to do that, Jenny. Just going to count for the full minute.
So equal chest expansion.
Okay, and I can see the respiratory
activity adequately.
Okay, and I can see that the respiratory rate is at 22, which is a little higher than I'd like for Jenny as she's in bed resting. The oxygen saturations haven't continued to fall, but they're not picking up as much as I'd like. But I'm going to proceed with my assessment, I think. That's probably all I can do for now in terms of breathing. So we'll move on to circulation. I think the next thing to do would be to attach the blood pressure monitoring cuff to Jenny's arm. I'd quite like to do an assessment of her blood pressure. I'm just also going to have a look while I'm doing that to make sure that Jenny has a point of intravenous access should I need it. There we go. Just going to check your blood pressure now, Jenny. Going to feel it go tight on your arm.
Okay.
Not
That's
for long.
fine, okay.
So we have one green cannula in this right arm.
Okay, and I'm just going to check either with medical notes or with Jenny how old that cannula might be.
So the date on the cannula is 2 days ago.
Okay, so I'm happy with that. And does the cannula in the arm look like it might be patent, no signs of swelling or redness or leakage? No signs of problems in the vein. Looks nice and patent. Okay. So that's good to know. So I'm just going to have a look at that blood pressure now that it's registered. Again, that's a little bit on the borderline side. Heart rate's not too bad. but oxygen levels really aren't rising. I quite like to check Jenny's temperature now, both an assessment of her limbs to see if she has cool or warm peripheries, but also an actual tympanic temperature measurement if possible. That's great. So we're just going to use this special thermometer, Jenny, that's going to measure your temperature for you. Just going to feel a pressure in your ear.
Okay.
There we go. Okay, that's fine. Jenny, are you feeling warm at the moment? Do you feel like you're hotter than you'd like?
No, I don't feel warm. No.
Okay. Okay. So we're going to keep an eye on that, but that's okay for now. I've got that for now. And what about Jenny's limb temperature? I'm just going to assess that to see how she's perfusing her periphery.
So she's warm to touch, upper limbs and lower limbs.
She's warm to touch. Okay. So my last thing I think for this would be just to check her capillary refill time. So we're just going to squeeze your finger, Jenny. Just elevate your arm slightly, and then we're going to count for a few seconds. All right.
Mm-hmm.
Just give us an idea whether you're dry or not.
So capillary refill time's 3 seconds.
Okay, so capillary refill is a little delayed, but again, her heart rate is reasonable. Blood pressure's borderline, and saturations are climbing slowly, and she is still talking to me. So I'm going to move on to D at that, but I do have in the back of my mind that there may be a potential she'd benefit from a little bolus of fluids at some point in the near future. But for now, I'm happy. So I'm going to move on to D. So, Jenny, can you tell me where you are, please?
Yeah, I'm in the hospital in Queens.
In Queens, that's smashing. Do you remember which ward you're on, Jenny?
No, I don't actually.
That's all right. And do you remember my name when we first met? Do you remember my name?
Yeah, Paul.
That's lovely. Okay, so I'm reasonably happy that Jenny's orientated. She's a little bit mixed on the ward she's on, but that could well just be due to the fact that hospitals are confusing places. But she seems to know where she is broadly and who I am, so I'm happy that she's alert and aware. So she's an A on the ACVAPU scale. I'm just going to check limb movements now, just to make sure she can move her limbs. So, Jenny, if you wouldn't mind squeezing my fingers for me.
So that's equal on both sides.
Lovely. And can you bend your elbows at all? Lift your hands off the bed.
Yeah, she's able to do that.
Lovely. And I'm just going to have a little check of your feet now as well, Jenny. So could you wiggle your toes for me on both sides?
Okay.
Yeah, she's able to do that on both sides.
And are you able to flex your knees at all? Yeah, bend your knees up a little. And your own power, how's that?
Yeah, that's fine on both sides. Equal.
Okay. So she's got reasonable power in her limbs, and she's able to obey commands. Last thing then, if I could find a pen torch around the bed space somewhere. Okay, Jenny, so a bit of a bright light now, just in your eyes. I'm just going to shine a light first from the left. Yeah, and then from the other left. There we go. That's lovely. Okay, a bit bright. Sorry about that, Jenny.
So okay. Pupils are equal and reactive to light, size 3.
That's great. So I'm really happy in terms of level of consciousness at the moment. If it would be possible, I'd quite like to just take a quick blood sugar at this point. So, Jenny, it's just a little drop of blood just from the tip of your finger. It's uncomfortable for a moment, but that's the worst of it.
All right, that's fine.
There we go. That's lovely. Okay, so I'm really happy with that number. Not too high, not too low. So I'm happy with that. Thank you, Jenny. Now, I'm aware that you mentioned your pain. Whereabouts is the pain sensitive? Where is it worse? Where is it coming from?
Well, it's just obviously I had my appendix taken out the other day, and it's just from that one spot basically.
So it's from
gosh, it is so painful.
So it centres on your operation wound. Is that what you're telling me?
Yes, as far as I'm, yes.
Does it go anywhere
yes.
else particularly? Does it radiate
No.
out at that point? No. Okay.
No, it's just there.
And you say it's got worse. How long has it been worse for? How long have you really started to become uncomfortable before you
I noticed it. Yeah, just late this morning, a couple of hours, but in the last hour, it's just, yeah, it's unbearable.
So over the course of the last hour, it's got a lot worse, and bless you, you managed to hold on. Okay. So if you were going to put a number to that, between perhaps 0 and 10, 0 being no pain at all and 10 being the worst pain you could possibly imagine, where would you put it in that scale?
A good 7, 8. Yeah, 7 or 8, I think.
Okay. So I really want to get you something to make that feel better. But to do that, I'm going to have to contact the doctor. I'm going to have to give him a ring because he's not currently on the ward.
Okay.
Before I make that phone call, I just want to complete my assessment by just checking your skin, if that's all right.
Okay. Okay.
We're going to draw the curtains around just to make sure that your dignity is maintained. There we go. Just going to have a little look just at the top of your shoulders and your neck and your chest. Anything to see there? No.
No.
Anything on the head? No. Anything at all? No.
No.
Okay, so moving down, anything upper limbs? Okay. And a good look. Yep.
No, nothing upper limb.
Okay, I'm just going to pop the blankets down just a little, Jenny, just so I can have a look at your tummy.
Okay.
I'm going to be really careful here because this is where your operation
Careful, I really. Yeah, please be careful. It's very tender.
So there's a wound here with strike through on the bandaging.
I can see that dressing. Yeah, I can see that's significant.
Yeah, that's painful.
Okay, so what I'm going to do, Jenny, is I'm going to go and get some sterile gloves.
Okay.
What I'd quite like to do is have a look underneath the dressing.
Oh, okay.
Just so I can have a really good look at the wound. That's it. So we've got some nice clean gloves. I'm going to have a little look now. Just bear with me.
Yeah.
As gentle as I can.
Oh.
Okay.
Yeah.
Here we go. Oh,
Really,
sorry.
Really
right.
hurts.
Okay.
So the wound looks red and quite swollen.
Yeah, I see that. Okay, that helps. Thank you very much. Right, Jenny. So what I'm going to do now is I'm just going to step away from this bed space just for a few moments to call the doctor because I'd quite like him to come and review you himself, and we really want to get you some extra painkillers to make you feel more comfortable. Is there anything else you're worried about before I go make the phone call?
No, I just something quick, please.
We're going to sort it out for you. Okay, I'm going to be briefly away making that phone call, and then we'll be back to you straight away.
Okay, thanks.
Thank you.